The endocrine system consists of glands and organs such as the pituitary, thyroid, adrenal, pancreas, and gonads, all of which secrete hormones directly into the bloodstream to regulate vital functions. These glands and organs maintain homeostasis through feedback loops. The pituitary gland, known as the master gland, sits beneath the hypothalamus and controls many body functions. It is regulated by the hypothalamus and has two lobes, the anterior pituitary and the posterior pituitary. The posterior pituitary releases antidiuretic hormone, ADH, which helps the kidneys retain water and maintain fluid balance. The anterior pituitary is tied to growth and master control of other endocrine organs. The thyroid gland produces thyroxine, thyronine, and calcitonin. The secretion of T3 and T4 is regulated by the anterior pituitary through a negative feedback mechanism involving thyroid stimulating hormone, TSH. When thyroid hormone levels are low, TSH stimulates the thyroid to release more hormones until normal levels are restored. T3 and T4 regulate metabolism, energy production, and the body's use of fats, proteins, and carbohydrates, and normal thyroid function is referred to as euthyroid. Calcitonin helps lower blood calcium levels by inhibiting calcium release from bones. The adrenal glands are complex because they function as two glands in one, consisting of an outer cortex and an inner medulla. The adrenal cortex secretes cortisol and aldosterone. Cortisol is released in response to physiologic stress such as infection, trauma, and hypoglycemia, and aldosterone is released in response to low blood volume as the final step of the renin-angiotensin-aldosterone system. The adrenal medulla secretes epinephrine and norepinephrine, which are released during stress and play key roles in the body's fight or flight response. The pancreas regulates blood sugar and metabolism by producing and secreting insulin and glucagon, each of which plays a role in maintaining metabolic balance. Disruptions in these systems can lead to a variety of clinical disorders. The posterior pituitary is strongly tied to fluid balance. The posterior pituitary releases vasopressin, also called ADH, and ADH increases the permeability of the renal distal tubules, so the kidneys reabsorb water. When ADH is deficient, we see diabetes insipidus. When ADH is excessive, we see syndrome of inappropriate antidiuretic hormone, SIADH. Diabetes insipidus is a condition caused by a deficiency of antidiuretic hormone, which is released by the posterior pituitary gland. When ADH levels are low or ineffective, the kidneys cannot concentrate urine properly. This leads to the production of large amounts of very dilute urine, excessive thirst, fluid imbalance, and increased fluid intake. There are two main types of diabetes insipidus. Neurogenic diabetes insipidus occurs when the body does not produce or release enough ADH, often due to damage to the hypothalamus or pituitary gland from head injury, surgery, or trauma. Nephrogenic diabetes insipidus occurs when the kidneys do not respond to ADH. This can be inherited or caused by kidney damage or from certain medications like lithium. Overall, think of diabetes insipidus as a water loss problem. In this, antidiuretic hormone from the posterior pituitary is either missing or ineffective. Diabetes insipidus then is characterized by the excretion of a large quantity of dilute urine because the renal tubules are failing to reabsorb water. It is also characterized by polydipsia. Therefore, the most common symptoms are sudden onset polyuria and sudden onset polydipsia. Urine output can reach between 3 to 20 liters of fluid each day, and excess thirst results in a consumption of 2 to 20 liters of fluid a day. Older adults are at higher risk for dehydration, not because the disease is different, but because normal aging includes a lower total body water content, reduced thirst sensation, and decreased ability of the kidneys to concentrate urine. Physical findings can include the classic dehydration-related findings like tachycardia, hypotension, dry mucous membranes, and loss of skin turgor. As dehydration worsens, you can see decreased cognition, weakness, fatigue, weight loss, muscle weakness, constipation, and nocturia. Laboratory findings in diabetes insipidus follow a clear pattern. Urine becomes increasingly dilute with a very low specific gravity and low osmolality. The blood becomes more concentrated, showing elevated osmolality and increased sodium levels. In the elevated osmolality, the blood is just simply too concentrated. The water deprivation test, also called the ADH stimulation test, is simple and a reliable way to diagnose diabetes insipidus. During the test, fluids are withheld to intentionally cause dehydration, while urine output and concentration are closely monitored. After this, a subcutaneous injection of vasopressin is given, which should cause the urine to become more concentrated. This would then increase the specific gravity and osmolality. If the urine concentrates after vasopressin, the condition is identified as neurogenic diabetes insipidus. However, if there is little to no change in urine concentration, the cause is more likely nephrogenic diabetes insipidus or a psychogenic polydipsia, which is related to the compulsive, excessive fluid intake. The medical management of diabetes insipidus requires prompt and aggressive intervention to prevent severe dehydration and circulatory instability. Treatment focuses on restoring circulating volume, replacing antidiuretic hormone when indicated, and addressing the underlying cause of this disorder. Because the body is unable to conserve water effectively, early stabilization is essential to prevent life-threatening complications. Restoration of fluid volume is the immediate priority. Patients who are alert and able to drink are encouraged to consume large amounts of fluid to replace the ongoing losses. When oral intake is inadequate or unsafe, intravenous fluids are administered using a fluid pump to ensure precise delivery. Hypotonic solutions are typically used initially to replace free water losses and gradually lower the elevated serum osmolality. Fluid therapy is adjusted based on the patient's cardiovascular status. If signs of cardiovascular compromise develop, fluid intake may be restricted until urine concentration improves and normal urine output resumes. Continuous assessment of hydration status is critical and includes monitoring heart rate, blood pressure, daily weights, intake and output, skin turgor, and mucous membranes. Accurate urine output measurement often occurs with a urinary catheter and is helpful to guide therapy. Blood and urine studies are monitored together to evaluate sodium levels and osmolality, allowing the care team to make timely adjustments to treatment. Treatment for diabetes insipidus depends on whether the condition is neurogenic or nephrogenic, since each type requires a different approach. Medication therapy also differs based on the type of diabetes insipidus. Neurogenic diabetes insipidus is treated with ADH replacement, which is most often desmopressin, DDAVP, or vasopressin, which can be given intranasally, orally, or by injection to increase water reabsorption by the kidneys and reduce urine output. When using vasopressin, assess cardiac history. Vasopressin can precipitate angina, hypertension, or myocardial infarction if increased dosing is given to patients with cardiac history due to its vasoconstrictive effects. In contrast, nephrogenic diabetes insipidus is managed with thiazide diuretics and salt restriction rather than ADH replacement. Patients with neurogenic diabetes insipidus must understand that they require a lifelong vasopressin therapy treatment. They should be taught proper intranasal administration techniques, which include clearing the nasal passages and sitting upright before inhalation. When taking vasopressin, the patients must also monitor their weight daily, and any weight gain greater than 2 pounds in 24 hours should be reported to their provider. Nursing care focuses on careful monitoring of the patient's condition. This includes vital signs, urine output, strict intake and output, typically with a catheter, urine-specific gravity, and laboratory values like sodium, potassium, creatinine, and osmolality. Daily weights are essential to track fluid balance, and IV fluids with electrolyte replacement may be needed, making sure that fluid intake closely matches urine output to prevent dehydration. Patients should be encouraged to follow their prescribed diet, which is usually a regular diet with avoidance of substances that increase urine output like caffeine. Fall precautions are important due to the risk of hypotension and weakness. If constipation develops, adding bulk foods and fruit juices to the diet can be helpful. Laxatives can be used if needed. Nurses should make sure that they're regularly assessing skin turgor and mucous membranes, and that they're providing gentle skin and mouth care using a soft toothbrush, mild mouthwash, alcohol-free products, and a moisturizing lotion to prevent dryness and irritation. Patients should be encouraged to drink fluids in response to thirst and replace fluids lost through urine output. Home patient education is a key part of the treatment. Patients should be taught to weigh themselves daily, eat a high-fiber diet, and carefully monitor their own intake and output. The patients should also be educated on the signs of dehydration, including weight loss, dry or cracked lips, confusion, and weakness. They also need to understand that fluid restriction may be necessary to prevent water intoxication. Alcohol should be avoided because this can also increase urine output. Syndrome of inappropriate antidiuretic hormone, or SIADH, is a condition caused by excessive release of antidiuretic hormone from the pituitary gland. ADH, also known as vasopressin, normally helps the kidneys conserve water. In syndrome of inappropriate antidiuretic hormone, too much ADH causes the kidneys to retain excessive amounts of water, leading to fluid overload, dilution of sodium in the body, and decreased serum osmolality. As water shifts between body compartments, dilutional hyponatremia develops, which can have serious neurologic consequences. Several conditions can trigger the hypothalamus to overstimulate and increase ADA release. Common risk factors include malignant tumors, head injury, meningitis, and increased intrathoracic pressure that is seen with positive pressure ventilation. Many medications are also associated with SIADH, including barbiturates, anesthetics, diuretics, chemotherapy agents, tricyclic antidepressants, SSRIs, opioids, and fluoroquinolone antibiotics. Older adults are particularly vulnerable because age-related kidney changes and medication use increase the risk of hyponatremia. Manifestations of SIADH are often subtle and include headache, weakness, anorexia, muscle cramps, and weight gain without visible edema, since water, not sodium, is retained. As sodium levels continue to fall, neurologic and gastrointestinal symptoms begin to appear. This includes personality changes, irritability, hostility, nausea, vomiting, diarrhea, sluggish reflexes, and decreased urine output. Urine becomes dark yellow and highly concentrated as water retention increases. With worsening hyponatremia, patients develop confusion, lethargy, and abnormal breathing patterns like the Cheyne-Stokes respirations. If untreated, severe sodium depletion can lead to seizures, coma, and death. Physical assessment findings often reflect fluid volume excess. Patients may exhibit tachycardia, bounding pulses, possible hypertension, crackles in the lungs, distended neck veins, taut skin, and rapid weight gain. Despite fluid overload, edema may be absent early in the condition. Intake typically exceeds output, which further contributes to water intoxication and neurologic deterioration. Laboratory findings in SIADH follow a predictable pattern. When you look at the urine studies, think concentrated. The urine shows increased specific gravity, increased urine osmolality, and elevated urine sodium because the kidneys are continuing to excrete sodium while retaining water. When you look at the blood studies, think dilute. There is dilutional hyponatremia, decreased serum osmolality, and reduced BUN, hemoglobin, hematocrit, and creatinine clearance. This is all because of hemodilution. Remember, urine concentrated, blood diluted is a helpful way to interpret SIADH labs. Management of SIADH focuses on treating the underlying cause and restricting fluids to prevent further dilution of sodium. Fluid restriction is the top priority and is typically limited to 500 to 1,000 milliliters each day. Dimethylcycline, a tetracycline derivative, may be prescribed off-label for mild cases because it helps increase urine output and correct fluid and electrolyte imbalances. However, this should not be used in patients with impaired kidney function. Nurses need to monitor treatment effectiveness by watching for rising blood sodium and serum osmolality levels, along with decreasing urine sodium and osmolality. Patients taking dimethylcycline should be taught to avoid taking it at the same time as calcium, iron, magnesium supplements, antacids, and dairy products, as these impact absorption. They also need to watch for signs of oral yeast infection and protect the patient's skin from sunlight, as this medication increases photosensitivity. In more acute or severe cases, vasopressin antagonists such as tolvaptan or conivaptan can be used in inpatient settings. These medications promote free water excretion without sodium loss, allowing sodium levels to rise more rapidly. While receiving these medications, nurses must closely monitor sodium levels and intake and output. Loop diuretics like furosemide may also be prescribed to help the kidneys excrete excess water. These medications must be used cautiously because they can increase sodium loss and worsen hyponatremia. Patients should be instructed to change positions slowly to prevent dizziness and report symptoms of low sodium like nausea, poor appetite, or vomiting. In severe cases of hyponatremia or water intoxication with neurologic symptoms, hypertonic saline, a 3% sodium chloride, may be administered intravenously in carefully controlled amounts, about 200 to 300 milliliters at a time. The goal is to raise sodium levels just enough to improve neurologic function. During this treatment, nurses monitor closely for signs of fluid overload and heart failure, including monitoring for distended neck veins and crackles in the lungs. Patients should be taught to report shortness of breath. They should track their daily weights, restrict fluid intake as prescribed, and watch for signs of fluid overload or neurologic changes. They need to avoid alcohol and notify the provider if symptoms of hyponatremia occur. SIADH can cause serious complications, including water intoxication, swelling to the brain or lungs, and dangerously low sodium levels. If these problems are not treated quickly, they can progress to seizures, coma, and death. Nurses must focus on catching problems early by closely monitoring for signs of water intoxication, like crackles in the lungs, distended neck veins, swelling, decreased urine output, or changes in mental status like confusion, headaches, twitching, or disorientation. Seizure precautions must also be in place, and blood sodium levels must be checked regularly. Patients should be educated on the importance of strictly following fluid restrictions to help prevent their condition from worsening. Due to fluid restriction, nurses need to focus on comfort measures to relieve thirst. This can include frequent mouth care, ice chips, lozenges, and staggered fluid intake to help relieve thirst. When caring for patients, it's important to use a 0.9% sodium chloride instead of plain water when flushing internal feeding tubes or when mixing medications and when diluting tube feedings, since water can worsen the fluid imbalance. You should closely monitor and maintain strict intake and output, and promptly report any decrease in urine output. Laboratory values should be monitored closely, paying attention to decreasing blood sodium and serum osmolality, along with increasing urine sodium and osmolality indicating resolution. Daily weights are essential. A 1 kilogram 2.2 pound weight gain reflects about 1 liter of fluid retention and should be reported to the provider immediately. You should also watch for changes in mental status like headaches, confusion, lethargy, or seizures, or coma, because all of this can indicate hyponatremia. Patients with altered levels of consciousness require a safe environment and seizure precautions. Go back and watch the video. It is a video that is embedded in that PowerPoint link. This video is an overview of the differences between SIADH and diabetes insipidus. Moving on to the thyroid system. Thyroid hormones act like the body's metabolic thermostat. The anterior pituitary secretes TSH, which then prompts the thyroid to release T3 and T4. Inappropriate amounts of T3 and T4 cause an increased or decreased metabolic rate, affecting all body systems. Hyperthyroidism is described as a clinical syndrome caused by excessive circulating thyroid hormones producing a hypermetabolic state. Remember, in hyperthyroidism, these patients very often present with nervousness, irritability, hyperactivity, emotional liability, decreased attention span, and mental and emotional status changes. They can have weakness, exercise intolerance, muscle weakness, heat intolerance, and insomnia. Weight loss with increased appetite, frequent stools, or diarrhea. On physical assessment, the skin is typically warm and sweaty and flushed. The hair is thin with a fine texture. Neuromuscular findings include tremor and hyperreflexia. In Graves-specific findings, there's exophthalmos with vision changes, excessive tearing, and bloodshot eyes. There's also eyelid lag, and pretibial myxedema. Cardiovascular findings include tachycardia, palpitations, dysrhythmias, elevated systolic blood pressure, and a widened pulse pressure. In this, TSH is decreased, and there is an elevated free T4 index and an elevated total T3, T4. Treatment includes thionamides like methimazole and propylthiouracil to inhibit thyroid hormone production. Beta blockers like propranolol, atenolol, and metoprolol treat symptomatic effects like tachycardia and palpitations. Iodine solutions like Lugols inhibit release of thyroid hormone for short-term treatment use before therapeutic procedures. Definitive treatment of hyperthyroidism includes a radioactive iodine ablation to destroy some of the thyroid-producing cells and a thyroidectomy, which is removal of part or all of the thyroid. Nursing actions after thyroidectomy include assessing for laryngeal nerve damage by assessing speech as soon as the patient wakes and then every 2 hours thereafter. The nurse also must assess for hypocalcemia and tetany due to possible parathyroid damage. The nurse should note tingling, twitching, Chekhov's and Trotsky's sign, and they need to make sure that they are able to provide IV calcium gluconate or calcium chloride if these findings occur and the medication is ordered. Thyroid storm is a sudden surge of large amounts of thyroid hormones, and this causes a great increase in metabolism. This is a medical emergency with high mortality rates. Precipitating factors include uncontrolled hyperthyroidism, especially in individuals with Graves' disease, infection, trauma, emotional stress, diabetic ketoacidosis, digitalis toxicity, and it can also occur following thyroidectomy surgery due to gland manipulation. Thyroid storm represents an extreme exacerbation of hyperthyroidism rather than a separate disease process. Thermoregulation is severely disrupted, and this results in high fever and profuse sweating. Cardiovascular findings include atrial fibrillation, supraventricular tachycardia, and signs of acute heart failure. Neurologic manifestations range from restlessness and agitation to delirium, stupor, or coma. Gastrointestinal symptoms include nausea, vomiting, diarrhea, and occasionally unexplained jaundice. Early symptoms can be subtle and overlooked, leading to a sudden and severe clinical deterioration. Because of this, structured diagnostic scoring systems are used to support clinical judgment. One such system is the diagnostic criteria you see within this slide. If you look closely at this, you can see that we are evaluating temperature, tachycardia, central nervous system effects, heart failure, gastrointestinal dysfunction like diarrhea, nausea, vomiting, and abdominal pain. We're looking for any kind of history, and the culmination of the points obtained from each section assessment results in a total that can either indicate if the thyroid storm is unlikely or if we should diagnose thyroid storm. The primary goal of medical management is to rapidly reduce the clinical effects of thyroid hormone while stabilizing vital organs. Treatment priorities include preventing cardiovascular collapse, lowering dangerously high body temperature, and correcting dehydration. Cardiac protection is central to the focus of treatment. We need to control tachyarrhythmias and prevent progression to heart failure. Beta blockers are a cornerstone of therapy. They are used to slow heart rate, reduce myocardial oxygen demand, and blunt the sympathetic overactivity. When beta blockers are contraindicated, some calcium channel blockers can be used cautiously, although beta blockers are the first-line therapy. Body temperature is reduced by using external cooling measures like cooling blankets and antipyretic therapy. Acetaminophen is the preferred choice for temperature elevation management. Medications that increase free thyroid hormone levels, like salicylates, are avoided because they can worsen the hypermetabolic state. Aggressive fluid replacement is required to treat dehydration caused by fever, vomiting, diarrhea, and excessive sweating. Isotonic fluids are commonly used to restore circulating volume and correct electrolyte losses. Glucose-containing solutions may be administered to replenish depleted energy stores. Pharmacologic therapy is essential and requires a multimodal approach, typically delivered in a critical care setting. Beta blockers are used to reduce tissue sensitivity to catecholamines. Antithyroid medications are administered to block new thyroid hormone synthesis and in some cases inhibit peripheral conversion of thyroxine to triiodothyronine. Antithyroid agents are used, and this offers the benefit of reducing peripheral hormone conversion. The medications do not affect hormone that is already released within circulation, however. Inorganic iodine is administered after antithyroid medication has been given and had time to block hormone synthesis. Iodine rapidly inhibits the release of performed thyroid hormone from the gland, but if it is given too early, it may worsen hormone production. Because thyroid storm can unmask or actually worsen adrenal insufficiency, corticosteroids are often administered during early treatment. These agents help reduce peripheral conversion of thyroid hormone and support the stress response. Body temperature is monitored frequently until stabilization occurs. Cooling measures include environmental adjustments, fans, tepid sponge baths, and targeted cooling at major blood vessels. Acetaminophen is used when medication is required and salicylates are avoided. Fluids and electrolytes are replaced carefully but aggressively based on cardiovascular tolerance. Blood glucose and sodium levels are monitored closely and abnormalities are corrected promptly. Ongoing hydration assessments guide therapy adjustments. Hypothyroidism is from inadequate circulating T3 and T4 that decreases metabolic rate and affects all body systems. Assessment findings include fatigue, lethargy, irritability, cold intolerance, constipation, weight gain without increased intake, pallor, brittle nails, depression, muscle and joint pain, bradycardia, hypotension, dysrhythmias, slowed thought and speech, hypoventilation, thick skin, hair loss including eyebrow thinning, and dry flaky skin. The labs associated with hypothyroidism include decreased T3 and T4 and increased TSH. Levothyroxine is the most common synthetic thyroid hormone replacement. When medicating with levothyroxine, it should be taken on an empty stomach 30 to 60 minutes before consuming food. Fiber supplements, calcium, iron, and antacids interfere with medication absorption. Myxedema coma represents the most severe and extreme rare manifestation of hypothyroidism. It is a medical emergency characterized by widespread depression of organ system function, and it is associated with respiratory failure, cardiogenic shock, hypothermia, and coma. What distinguishes myxedema coma from uncomplicated hypothyroidism is the profound suppression of central nervous system activity. Patients develop progressive deterioration in mental status, ranging from lethargy and stupor to complete coma. The diagnosis of hypothyroidism that is end stage, including myxedema coma, is made from the patient's clinical presentation. As thyroid hormone levels decline, patients develop progressive signs of reduced cellular activity, including depression and slowed mental processes. Mental status continues to deteriorate as the disease advances, reflecting widespread metabolic suppression. Interstitial edema develops throughout the body as mucopolysaccharides accumulate within tissues and infiltrate organs and impair normal function. Patients can present with cardiovascular collapse, profound hypothermia, reduced kidney function, fluid overload, hypoventilation, and severe metabolic disturbances. Weight gain is common, but results from fluid retention and decreased metabolism rather than increased caloric intake. Neurologic symptoms include paresthesias of the hands and feet caused by nerve compression, and this often leads to carpal tunnel syndrome. Fine motor function becomes impaired, and deep tendon reflexes characteristically relax very slowly. Hypothermia is one of the most distressing features, and it's frequently noted during colder months. Cardiovascular findings include hypotension, decreased cardiac output, and bradycardia due to reduced beta-adrenergic stimulation. Depression and cognitive slowing worsen as hypothyroidism progresses in myxedema coma. TSH is the first test to order if hypothyroidism symptoms are suspected. Patients with myxedema have primary hypothyroidism with a high TSH level and low T4 level, but there are no specific lab tests to evaluate for this. Management typically requires intensive care, including ventilatory support, correction of fluid and electrolyte abnormalities, cardiovascular stabilization, corticosteroid supplementation, and thyroid hormone replacement. Thyroid hormone replacement is complex, and it has to be carefully individualized. A common strategy involves an initial intravenous dose of levothyroxine to replenish depleted hormone stores, followed by a lower daily maintenance dose. Because adrenal insufficiency may be present or unmasked by treatment, corticosteroids are often administered before or alongside thyroid hormone therapy. Many patients require intubation and mechanical ventilation due to respiratory depression. Those not intubated are closely monitored for respiratory failure, and arterial blood gases are used to assess carbon dioxide retention and acidosis. Continuous ECG monitoring is essential as dysrhythmias are common. Typical findings include low voltage QRS complexes, flattened or inverted T waves, and prolonged conduction intervals. Hypothermia improves gradually with thyroid hormone replacement. Passive warming with blankets may be sufficient for mild cases, while active warming devices are used when necessary. Temperature is monitored closely to avoid overly rapid rewarming and cardiovascular instability. Thyroid hormone is administered cautiously, especially in older patients or those with cardiac disease, as treatment can precipitate angina or dysrhythmias. Clinical improvement and trending thyroid hormone levels help guide therapy. Dry, flat, fragile skin is protected with gentle cleaning, emollients, and frequent repositioning. Constipation is managed proactively with fiber and hydration when tolerated. Enemas should be avoided when possible. Within this slide, there is another video embedded. This one is about 20 minutes in length and goes into the differences comparing myxedema coma to thyroid storm. Take a minute and review these videos